Okay. And so, because we are getting close to the start of the program, I think your microphone is a little bit. Is it clear? A little bit. I think.
My microphone?
Yeah, yours. Can you come closer? Yeah.
Yes.
I think.
Oh, can you hear us better now?
Yes, at least for me, and perhaps
We're so sorry. We didn't. We do it for like with we're doing with you live first time, so we didn't really know how it's gonna work. But if you need us to make it louder, we can make it louder, no problem.
Thank you so much. I will begin with introduction of Dr. Beg, and then for you, Dr. Gergov, Mr. Gergov. Sorry.
You can just tell me Leon. It's fine. Thank you.
Okay.
You want to share screen and put the presentation slide on, Doc? You want us to put the presentation slide?
Yeah, it's live. Yeah. I want to say hello to our colleagues and our students and audiences. Thank you again for joining us at our program. It is the second and the final day. Today we are honored to have Dr. Beg, Dr. Bobby Beg, and Ms. Leon Gergov with us. And we continue to with other lectures, and we will be happy if you follow us and join us at our practical course at Tehran University of Medical Sciences. Let's begin with Dr. Bobby Beg. Dr. Bobby Beg received his dental degree from HKES Dental College, Gulbarga University, India in 1997. He has completed his residency at Government Dental College and Hospital in Hyderabad, India. Dr. Beg completed advanced education in general dentistry program and graduate program in prosthodontics at Eastman Institute for Oral Health, University of Rochester, New York State, USA. Dr. Beg is an associate professor at University of Rochester in the Department of Advanced Education in General Dentistry at Eastman Institute for Oral Health, University of Rochester, USA. He also works as a clinical instructor in prosthodontics in MT Sinai Hospital and associate in dentistry at University of Toronto, Faculty of Dentistry, Toronto, Canada, and private practice at Dental Specialists Group, Woodbridge, and Prosthodontic Associate, Toronto in Ontario. Dr. Beg is a board-certified prosthodontist in Canada and serves as a national examiner for NDSE, National Dental Specialty Examination Board. The licensing exam to be a prosthodontist in Canada and national examiner for prosthodontics fellowship administered by Royal College of Dentists of Canada. Dr. Beg was awarded the Part-Time Faculty Award for Excellence in Teaching by the University of Rochester, New York City, USA for the year 2019. And Dr. Beg has a special interest in aesthetics and implant dentistry, reconstructive, fixed, and removable prosthodontics, dental ceramics, and smile makeover procedures. Dr. Beg lectured extensively to dental study clubs and professional organizations across North America and Southeast Asia. Thank you, Dr. Beg, for joining us. It is a great honor and pleasure to have you with us. Thank you for accepting our invitation. And let's go to Mr. Leon Gergov. Yes, I'm saying correctly, Mr. Gergov?
Yeah.
Thank you so much. Mr. Leon Gergov was born in Russia in 1988. He moved to Canada in 2005. He acquired an advanced diploma from George Brown College in 2010 and completed successfully the requirements of participating dental technology in Ontario in 2011. being the youngest dental technician granted the title of registered dental technician in province. Leon is a member of Association of Dental Technologists of Ontario, a registered active member of College of Dental Technologists of Ontario, a member of Dental Technology Academy of Aesthetic Academy, and a member of International Congress of Oral Implantologists. To further his education in the field, Leon eagerly participates in all continuing education seminars and courses offered throughout North America and Europe. And he has attended a number of hands-on courses with great technicians of dental technology. Of course, because we don't know their names, so I don't. In 2016, Leon attended the bioemulation meeting, and in 2017, he became an ELAB instructor for North America, adding substantial knowledge and skills on his daily portfolio. With the recent transforming technology, he has delved in depth into the CAD/CAM applications for complicated and multiple restorations. His knowledge and expertise make him an asset for several companies when software improvements are being implemented. Leon's extensive experience of working on highly aesthetic implant-supported restorations, his constant experimenting with different materials to achieve optimal aesthetic results, and relentless drive to learn and apply innovative techniques to better the patient's experience are some of his pivotal qualities to building a solid foundation for his career in dental technology. His enormous home-based libraries enriched frequently with vintage and contemporary books, magazines, manuals related with principles of aesthetics, a wide array of cases represented from technicians all over the world with advancement of technology and materials alike. His perpetual desire of expanding and improving his skills is fascinating and meticulously inspiring. Thank you, Mr. Gergov, that you have enjoyed.
Thank you.
Thank you so much. So
That was like a textbook of introduction, Dr. Farid.
I've done a lot of things. I enjoy the profession.
Hold on, I think, is the screen frozen?
A little bit, I think so, because we are live as well. So. Hello. There you go.
Yes.
yeah,
Now you're back.
A power connection problem. So if you don't see us, please you continue.
Okay, so obviously we need your help during the presentation. So at least we know that if our internet got stuck here by any chance, we don't want to miss out some important information, so we can go back and start from those slides. So again, good morning, everybody. Thank you so much for joining us today. And it's been almost, as I said, more than 18 hours been working, but still we're gonna stay fresh to make sure that we entertain you guys enough today with all the beautiful and fantastic cases what we have. First of all, I wanna thank Dr. Farid for really having us and recognizing the fact that we were able to add value to our education today. And I can promise you one thing, that we're not gonna bore you. We'll provide you a lot of good information. And when I got the invitation for the first time, I was very excited. I thought, oh my God, I can travel to Tehran. And I said, hey, Leon, we need to go there and check it out, because the best thing I like about Tehran is the street food. So can't wait to come there and really enjoy the stuff. So hopefully someday things gonna be, yeah. And the good thing is in Toronto is like almost half Tehran, where you can find some amazing cuisine, because one of my favorite restaurants in Toronto is called Shatter Abbas. Probably there is actually a branch in Tehran as well. And the best kubide, I'm sure you guys have the best ones there, but trust me, these guys are also pretty good. So every time you go and enjoy there, we really feast on the food. So Iranian cuisine is fantastic, amazing, and you guys have a diversity of culture, knowledge, history. Yeah, when you talk about history, yes, Persian history has one of the largest and longest, what we call the earliest civilization for teaching. So Iran has a lot of foundation about with history. So it's amazing. Can't wait to come and check this out when we come to see you guys there. Okay.
Next year when COVID is over.
Of course, of course. So without any delay, we will.
Pleasure to have you with us at Shutter Abbas, especially, and to have you here in Tehran. It would be our honor and our pleasure, great pleasure.
Fantastic. So, again, so without any delay, we just wanted to talk about the presentation. So my name is Bobby Beg. I'm a prosthodontist, and this is Leon Gurgav. So everybody can call him Leon, and so at least easier. You can call me Bobby, so it's much easier for you to remember our names. So, so today we want to talk about full arch restoration from design to delivery. So yesterday you had Dr. Esther Gans. She's also from Toronto as well. Fantastic lady, great knowledge, and I was told that she spoke about the dynamic guided surgery. So it's actually pretty amazing and intense. And actually, I was talking to Dr. Farid this morning that we have been teaching our residents in Rochester from the last 2 years how to embrace this technology with the treatment. So the fun part in the pandemic is to work in 2 countries, 2 universities, 2 private practices, and work with somebody like him, who's a fantastic guy, who has some great knowledge with ceramics and being one of the top ceramics in Canada. So yeah, don't look at his age, okay? This guy looks pretty young, but he's super talented, and you can say his word. You know, I'm not just saying this as you keep on making progress in the presentation. So
this is one of the slides of basically what do you have here beside the part that's me and that's the lab name. For every case that we do individually, I do a model from wax. So if I don't see the patient, I can mimic a natural case. So on top of it, I do my own cases. So that's just the wax, it's not a real teeth. And on top of it, I put the EMAX or the any full-spathic restoration that I do on top. It's like a checkup model.
is this picture when you're 16, Leon?
No, it's actually this picture for 5 years ago. COVID made me a little bit more rounded because we were sitting at home for quite some time, but you know, the hair was shorter, definitely.
So
I think
anytime,
Shutter Abbas.
Yeah, I was actually eating a lot of good food.
so anytime you have this major reconstructive cases, the biggest challenge is we need to have a very good systematic approach with aesthetics, biological, functional, and aesthetic challenges. That's why to be very successful, we really need to have very good selection criteria with our patients. So because today's presentation is purely geared upon how we can plan or implant cases from design to delivery. There's actually a journey which happens from beginning to the end. So to be very successful, we really have to understand what level of implant position you're going to be placing for this restoration. How much amount of peri-implant soft tissue you have, 3 millimeters, 5 millimeters. Is there any existing pre-existing conditions which can compromise your final outcome in terms of patient having bleeding, infection, separation? Now, what to expect when you do a prosthetic design? Would you run into any major complications or minor complications during chairside or long-term? Aesthetic challenges, functional challenges. Actually, one of my biggest topics which I lecture is about prosthodontic complications. And someday, if you like today's lecture, maybe I'll come back again and talk about what are the complications with implant dentistry. So our end goal with our patients is how satisfied our patients are. Are these patients happy? Did we meet their aesthetic expectations? Are they able to enjoy the prosthesis? So these are the very important criteria we really need to take into consideration. So when you talk about full prosthodontic rehabs, the most important aspect would be is to have a proper diagnostic protocol. So if you look at this slide, there are 4 primary things you really need to take into consideration. The number 1 is the bone volume, the smile line, how much amount of lip support you have, and what would be a final outcome of a gingival prosthesis. Now, if you look at this slide right now, I have outlined you in the maxillary and the mandibular radiograph to explain to you the type of bone which is available, what kind of challenges you can place when you have this kind of bony anatomy. For example, type 1, type 2, type 3, 4 bone, you really changes the goal of your treatment. So that's why it's very, very, very critical. Now, when you talk about the smile line, now, for me as a prosthodontist, yes, for me, bone volume is very critical. I wanted to make sure that we have a good outcome with the patients. But one thing what really makes me worry is patient's smile line, because Smile is like a curtain. We have to make sure that what kind of smile line this patient has. The first question I ask my patient before even doing any assessment, can you please smile at me? And especially now with masks, it's so challenging that we have to tell them that, can you take your mask off? So at least you can smile. It's okay, I can sit next to Leon because we both are vaccinated, so I'm not going to give you anything today, so don't you worry. So the slow smile line, these are the most challenging patients we have. Let me go back to this slide here. So slow smile line means you're not showing any teeth. Average smile line, you do definitely show around 60 to 70% of the teeth, but you see a very minor amount of interproximal tissues. High smile line means you're showing a massive band of 3 to 4 millimeters of soft tissue. So all these patients can really create challenges for you because the amount of gingival display really will create a massive roadblock. So that's the reason the most important, especially with implant restorations, is the PTJ, which is the prosthetic tissue junction interface, plays a major role. So we, for prosthodontists, this interface is one of the most challenging interfaces what we face when we have to design prosthesis. So, but again, there are different reasons why these things can change. Some patients have dental related issues. For example, they have a very dental alveolar extrusion because these things have super erupted, or sometimes it's because of gingival, because it can be hypermobile lip or altered passive eruption. So all these things can create an issue. And again, sometimes it can be skeletal too, where, for example, patients have a vertical maxillary excess because the volume of maxilla will be much longer. So at least the patient is going to show a thick band of bone and the soft tissues. Now, when you have these patients on the right side of the screen are dentate patients. Now, if you look at the left side of the screen, you see all these patients are edentulous patients, but when they smile, they already show the amount of residual, vestibule, and also the crest of the rib. So these are our most challenging patients. So designing fixed prosthetics in this patient can be very challenging. So we have to have a great foundation about pre-diagnostic markup, treatment, assessment, so that we know what kind of prosthesis we can offer to these patients. And finally, pink, which is the gingival part of the anatomy. So as I showed in the previous picture, if you cannot sink the pink, you cannot get the final outcome what you're looking for. So we want to make sure that we do not show any pink in our prosthesis because that interface can be quite challenging when you plan for your patient. So that is why a lot of times lip support is very, very critical. So it can be subjective and it's a perception. It's influenced by many, many factors. So you have to really have to understand what kind of lip support this patient has, because a lot of factors which can affect it. For example, inclination of the maxillary anterior teeth, how much amount of residual alveolar bone is available in the maxilla, how exactly are these muscles are able to function around the bony architecture, right? And again, sometimes length of the nose, the angulation. So what you can see here right now in the angles, it can be an acute angle or obtuse angle. So that angulation also can make a difference. So a lot of all these factors can really make a big difference for our patients so that it can really help to make a decision whether are we providing lip support for this prosthesis or not. It can be removable prosthesis or a fixed restoration. Now, sometimes when you look at the fourth option, which is the gingival prosthesis. Now, if you look at the top three pictures, you have this patient with a white gummy smile. Patient has a very irregular gingival architecture, which is visible in these pictures. Now, when you have made a decision for this patient that this teeth has to be extracted, you plan to an implant level restoration. How much amount of bone reduction is needed? So all these details will be provided by the surgical guide. That is why you really have to know how much reduction is to be needed, where exactly the implant platform will be positioned, how much amount of transition zone going to be there from the implant platform to the prosthesis, so that that zone is not clinically visible, that can be hidden inside the patient's mouth. That is why we need to make sure that we do a lot of focus on implant treatment planning, because with the new advancements in digital technology, we were able to embrace so much changes what we are looking for in terms of where exactly our goal can be for doing the final prosthesis. That is why when you collaborate with the lab, it's a huge synergy between the lab and the restoring dentist and the surgeon to see what's going to be your end goal in mind.
And the important part of all this is when you do collaborate with the lab, the idea is that due to the new dental digital dentistry, the new surgical guides, the new stackable guides, the new procedures of putting new landmarks in the patients, you can go from just planning the case all the way to the Rolls Royce of dentistry, which is single crown, single implants, separating the implants as it is, or even if it's a full hybrid zirconia, or if it's wraparound denture or not. Now, we'll start all the way from the beginning. We'll go to the surgical guides, stackable and unstackable.
So today's presentation, actually, we want to really stage in such a way that we get a beautiful understanding about the journey from start to finish. So step one, we're going to talk about digital planning, guided surgery, how we plan with with the impressioning process, with conventional and the digital, and what are the challenges, what we can face when you're doing this full arch restoration. So let's start with the digital planning. So digital planning is a very, very important criteria. For example, what we have, okay, so when you talk about digital planning, right, we kind of want to simplify things, the 5 easy steps for digital planning. So obviously for prosthodontists, for us, the most important thing is to do a proper digital diagnostic impressions. And the second is the CT scan, wax up and mock-up, how we integrate the data, digital planning with and without guides. So all these multiple factors we're going to discuss in greater detail. Now, all these criteria of these 5 important steps are very important to us because it doesn't matter if you're doing a fully edentulous patient or a partially edentulous patient. Now, when you talk about a partially edentulous patient, you already have some set landmarks because you're looking at the soft tissue, you're looking at the smile, you have the adjacent teeth. So these framework will help you to understand what you're trying to able to squeeze in with your final prosthetic. But with an edentulous patient, there's no landmarks there unless you really start taking some major anatomical landmarks so that you can establish the dental landmarks in the patient's mouth. So that's why it's very, very critical. So when we do cases, as I said, for us, the important step is the impressioning process. Now, it can be conventional or the digital. Now, from a lab standpoint, anytime you do a digital impression, what are the benefits here?
When you do a digital impression, the advantage of it is that you don't lose any time. By not losing any time, so when the dentist takes the dentist, the general practitioner, or the prosthodontist, we can involve the whole team, the surgeon, we can do the CBCT scan right away. And in the next slide, we'll show you how by taking the CBCT scan, by taking the intraoral scan, how we take all of them. In this case, so basically we just want to show a mock-up quickly. A guy came, he was missing some teeth. So the Dr. Beck took some intraoral scan, sent it to me, and I gave him like a digital smile design. By doing all of that, we can right away involve the patient in the whole procedure. Because let's say if he would have done it conventional way, he would have taken the alginate, I don't see the patient, I don't know who it is, he sends it to me, I wax it up like the old-fashioned way, which still works amazingly. I wouldn't be able to do all, in the next slide I'll show you, I do some diagnostic data. I take facial analysis, I mark the midline, the interpupillar line, the canine lines, just to show where I want to take the patient and where he was and what's the destination. Now, all those information with digital dentistry, I involve the patients and I'm getting involved with the dentist from day one, from the beginning. So we kind of showing the patients what's the process, where are we taking him from A to Z? And in that way, first of all, what are we gaining? We have so much data. And second of all, we involve the patients in the whole procedure so it sees what actually goes behind the scene with the whole process. So in these diagnostic cases, what we do after giving everything to the patient just on the picture, we actually go, we print models, we do mock-up directly in the mouth, we measure everything, we show where we moved from A to Z, how did it work, and kind of, that's basically a printed model of the same guy. So I just literally press the button and I printed it.
That's the beauty of doing digital markups. And
Yeah.
Now, if you look at these two gentlemen in this picture, so you can see right away the huge transition in their smile. Now, we didn't do anything much. We used digital smile design, clinical photographs, doing digital markups, just help us to educate the patient what they have been missing all this time. We're able to explain to them how much we can improvise their smile, how much we can bring back their, what you call the facial aesthetics and the comfort zone. And they were so happy. And if you look at both the pictures, these both gentlemen, they jumped into it and said, you know what, Dr. Beg, we're going for the treatment. And we definitely want to make these changes. So what happened is, number one, we did internal digital, what do you call it, so impressioning. Second thing is, we already took the CT scan. Number three, we have the mock-up, the wax-ups. Now, either it can be a conventional wax-up or digital wax-up. So what the lab does is, they scan all this data. So we can overlap and overlay all these things. Now we already have, you can see on the left side of the screen, we have a model with the missing teeth. On the right side, you see the diagnostic wax-up, and we have the DICOM file. Once we have this layering of the interface, we know exactly where the implant position is going to be. So based on that, we can create a perfectly planned guides for our surgeons. So now again, I do place my implants, but all the big cases, I love to work with surgeons. I'll tell you the names during the presentation, who these gentlemen are, and they're fantastic surgeons, and I'm very proud that I work with them. Now, guides can be bone-supported guides, soft tissue-supported guides. So even if you're doing all the digital planning, the guides, what you're going to prepare, which I'm going to show you in our presentation, how they were very helpful because it's synergy between the lab and the prosthodontist and the patient. We already know what direction we are heading. So these really help us to know exactly where the implant's going to be and what angulations, positions, depth. So this really helps us to know where these are going to be placed so that we can have a beautiful outcome.
Just adding to what Dr. Beck said, by doing those surgical guides, it's not like we're just building up a predictable dentistry. We make sure that we don't deviate from the plan. And by not deviating from the plan, so our mock-up stays relevant to the final product. Because when you start improvising and doing different things, you deviate from the plan and your prosthesis, and the final result is always not as you planned for the patient. In those case scenarios, that's when you lose the trust of the patient. And it's normal, it does happen sometimes because people do expect only the best from us. And together we try to make sure that it doesn't happen.
So let's talk about some cases to see how we manage these patients. Now, for example, you're looking at two panoramic radiographs. Now, based on these two X-rays, you can tell that most of the dentition is failing. So there's barely any opportunity that this can be salvaged. So patients, when they walk into our practice or in the university, we spend a lot of synergy and time with our patients because they come with a lot of expectations. Now, this lady, very pretty, beautiful, and her biggest concern was she didn't like how her anterior teeth are. She got a lot of work done in the past, but she said, you know what, I want to improvise my aesthetic. So in this process of making a diagnostic assessment, we found out that most of the dentition is failing and patients cannot, and yes, you have the problem with the two front teeth, but we made a full comprehensive assessment. The whole thing was that we cannot able to salvage all these teeth. So the plan that what we presented was to extract all the teeth. Now, for such a young lady, a beautiful lady, for able to lose all these teeth and make a decision that she's going to be removing all these teeth and providing her increased interim and transitional prosthesis, it was very hard for her to accept as a treatment. But with the comfort and the way we educate our patients, we want to make sure that we provide the best care for the patient. Now, once you tell the patient that you're changing the whole dynamics of smile, then they bring you with pictures. So she brought this picture. Okay. Sorry,
They come with a high expectation, basically, and whenever they come with the very high expectations, they want us to pull the rabbit out of the hat, which is sometimes impossible because we deal with different facial structure, with different smiles, but we educate them to give them more an overview of what they can actually have, and it's realistic to their smile. Like Dr. Beck said, whenever we met this patient first time, she came and she said, I don't like the difference between my centrals. One is longer, one is shorter. And when you look at it, you're like, okay, it's a simple problem. You just fix one tooth, right? Or two of them and you're done. But when you start analyzing everything and you present the treatment plan to the patient, she obviously first thing what they feel, they're like, oh, they're stressed out. I came for 2 teeth, I'm getting a full mouth. But if you do it the proper way and they come and they address the problem, then you have more cases acceptance from the patients.
So now when she came back and she showed me this picture of one of her, she found in the magazine, he said, Dr. Big, I want to smile like her. Like, oh, wow, okay. Now because you're really going to do transformation of your smile, now is a perfect time for you to provide me with pictures. That is why the most important thing is we have to have a great knowledge of prosthetic design. Where exactly the new tooth position is going to be, proper proportions of the teeth. Like for example, if you look at preclinical pictures, her tooth proportions were not ideal. Tooth levels were not the same. The aesthetic was not very acceptable for the patient. So all the modifications, the aesthetics, tooth position, functioning, all these things has to be taken into great consideration. Now, having said that, the most important thing is we all go back to the design principles of complete dentures, because complete dentures are very important for us for able to sorry, Leon is ahead of me.
No, it's not me, it's a computer, it's double clicks.
Okay, so even for a full mouth rehab, the basic foundation is to do a proper diagnostic tooth setup. Now, you'll be very surprised, this tooth setup, we have done it today. So she was in the department today in the morning and we did the trying setup. I took a lot of different profile pictures. So now we take a lot of pride in taking pictures. With me, when I walk in the residence, with my residents, I always tell them, if you don't have loops, if you don't have camera, don't bother talking to me because there's no more teaching happening. You have to have these two. You want to be part of my teaching program, you need to have these two. If not, find somebody else. There are a lot of other faculties in the department, they'll take care of you. If you want to be the best, you need to document your cases. Without documentation, you cannot. Now look at this pretty picture. And this patient, when you show them that how much changes you brought in a smile when she came first time and now this is a roadmap for us. So that is why, as I said, we spend time taking photographs of patients. Like for example, this beautiful lady, we did like 8 veneers for her, and my residents, they're taking photographs because we teach them how to take pictures, different angles, positions, so that at least when we show to our patient that how we want to document these cases, so they see the value of how we're trying to change a smile and aesthetics every time we do a different type of crime.
Now, moving after the pictures is back to the dentures protocol. When we do the denture protocol, we make sure that we try to stay within the proper portion of all the teeth and the landmarks. We duplicate the same dentures with a clear stem to be used in the surgical guide. This is a conventional surgical guide. Now, on the next slide, what we do, we cut the flange to see our anterior posterior spread and to see how much more tissue and lip support we have to do. After we do that, in this case, this lady was presented. She does have a very high smile line, which makes it a very unfavorable case. And you can see it over here. Now we did in her case, we realized that we need to change the implant position. So what we've done, we did another surgical guide where we did all the teeth in radiopaque. So when we do the CBCT scan, we can see where is the ideal position of the teeth. In this case, we've done a flange and not flange because some patients concerned about lip support, especially ladies, they want to make sure that the lips are not falling in. And today in our DNA time, people kind of want more lip support and more kind of feminine lips. And in some cases, you don't even need the lip support, not by teeth, not by flange, just by teeth, and that's the case. In new era technology that Dr. Beck was just explaining us today, you have something that's called
Yeah. So now in the previous slide, you have seen how we have created radiographic teeth with diagnostic tooth setup. But now sometimes patient comes into your practice, they have some beautiful dentures already there. So you don't have to reinvest money to make a new diagnostic tooth setup because patient is already pleased with the new tooth position. So what we do is we add this very fancy radiographic markers, which you're seeing right now, like this little brown, like white studs on top of the denture. So we will place the stickers. So basically, you have to have at least 6 to 8 of them on the denture. I don't know how much you guys are familiar about this, but what we do is we place these radiographic stickers on the existing dentures. We're not duplicating anything. We just take the denture, scan the patient, the CBCT and the denture. Now you can see in the lower left side of the screen that we have the existing denture being documented in the CT scan, and we can know how we can plan. So based on this data, we know exactly what's the amount of prosthetic space available for us, right? So now the most important aspect of really making this assessment is because you want to have a proper diagnostic tool setup. Now, if you look at these 4 top mounted models of this patient, actually, it's a very classic study done by Swati Ahuja. She actually talked about what's the existing interocclusal space available and how would that influence your final prosthetic outcome. So for example, if you look at the white line, which is actually the occlusal plane. So that's the occlusal plane dividing your upper and lower arch. Now, if you have around 15 millimeters of end space from the occlusal plane to the crest of the ridge, that's a very decent amount of prosthetic space. Now, 15 is great, 12 is slightly smaller, yes, 9 is less, and again, 5 is very less. Now, when you have a reduced intraocclusal space, that's the time things get very challenging. So how do we really know how much physical space we have? That is why if you look in the bottom of the screen, we have patients for a dentulous, you get a diagnostic tool setup, we have a radiographic markers, radiographic guides. So using the CT scans, we can exactly know how much physical space we have. Based on this, we can identify and tell the patient how much amount of space is available. Based on that, the prosthetic design can be recommended to the patient.
The 15 and 17 millimeters he sends to me, the rest he sends somewhere else. No, I'm joking. In this case, I'll show you in the next slide, I'll show you basically by what Dr. Beck was explaining the distance, it will determine how much room I have to do my work. And my work is kind of getting complicated because the less room I have, the less aesthetically pleasing case I can give, but mostly all of them want very aesthetically pleasing cases. So when it's less than 15, it's going to be type of screw retained denture or something like that. Maybe even with a bar reinforced or maybe hybrid. Between 8 to 10 millimeters, we can do a nice metal ceramic screw retained, maybe even cementable. And the favorite, above 12 millimeters, that's what I enjoy extremely to do because I restore everything. It's a zirconia with hybrids, with bars reinforced, and sometimes even single crowns, which is fun to do, and it's very beautiful cases.
So now, because we have a great roadmap about digital planning, how much physical space we have, how would the prosthetic design is, so let's talk about the next phase about, okay, you know what, we already know how much physical space we have for our intraocclusal space. Now, from a surgical standpoint, let's talk about surgical phase, right? So guided surgery has been very instrumental how we have been doing our cases. Now, it really helps us to have a great roadmap about the digital planning. So when you plan your case with CBCT scans, what's the best advantage, right? Because obviously, you know the tooth position, you know the bone volume, you know how much amount of physical bone you have. You can identify what implant diameter you're going to be placed. You can identify the major anatomical structures which you can run into while doing the surgical process. So, because one thing, guys, you keep in mind, implant dentistry is prosthetically driven. So we all have to accept the fact that, yes, our surgeons can place the implants. If I cannot restore those implants, then they're not good for me anymore. That's why digital planning really helps us to have a great roadmap. So, but there are some of the disadvantages for this, like for example, cost or surgical armamentarium. But good thing is, for me, we don't have to invest all the finances for investing in technology. Labs also have great support from doing procedures too. So they have softwares with them so that they can help us to plan the cases. So for example, right now, we get the radiographic report from the surgeon, we did the CT scan for our cases, we know how the physical intraocclusal space we have. Based on that, we know that we can design our cases. So let's talk about how this CBCT help us to plan the cases surgical standpoint. So because we talked about this topic as guided surgery topic, let's talk about the guides themselves. The first one is the bone supported guide. Now,
Bone supported guides, sorry.
So this is our first patient. Now, this gentleman, obviously, he looks like a nice football player in US, and he had this fancy teeth, but he said, Dr. Big, my teeth are failing. I was told that I'm not going to have this teeth for a long time. Now is the time I want to do something. Look at him right now. He's a very young man, 45-year-old. He came to the department, and with my residents, I'm working in this case. And the case will be quite challenging because he's almost like 6 feet 7 inches tall, very tall guy, handsome man, beautiful anatomical structures, but all his existing foundation is failing. Now, with him, what happened is the proposed plan was to extract all the teeth because all of them are failing to different regions. Now, obviously, we extract the teeth, we did some basic socket preservation, especially when his ethnic background, a lot of times we have amazing bone volume. So sometimes we fight with the patient that we don't have enough bone. Somebody like him has too much bone. Now, yes, we extract the teeth because now those teeth are failing for biological reasons, but we did not see any periodontal issues in this case. But we have to extract the teeth. Now we have to provide this patient with an immediate denture. Now, we made an immediate denture. He's happy with the immediate denture. But the question here is, can I do a fixed prosthetic rehab in this case? So what the step one is, we have to have an immediate denture. Then we went back and did a new diagnostic tooth setup. Based on the tooth setup, we did a CT scan. So if you look at the CT scan right now, if we have to know where exactly the implant is placed, but keep in mind, in his case, we have a bone reduction guide. So this radiographic guide, surgical guide, will help us to know how much amount of physical bone is removed, has to be removed. Like for example, if you look at this 4 cross-sectional slides, anything marked with yellow is where exactly will be our marking for the bone reduction, and the blue markings are for the guide stabilization pin. So next slide, please. Now, if you look at here right now in the radiographic guide, so if you look at the top of the the 6 lines in the buccal and the blue dot. So the blue dots are the stabilization pin. So what we do is yes, this is actually a bone supported guide. Now you see this patient, the flap is raised. The surgeon is Dr. Alexis Gannon, he's an oral surgeon in the department, the director of the program. So what he did is he raised a flap. We use the pins as landmarks. So all these things is already pre-planned in the computer. So once he raised the flap, the pins are really recognizing where exactly how much bone reduction is done. If you look at this slide right now with the perio probe, we had to remove 5 millimeters of bone because we needed that much amount of reduction. So the guide was help us to identify, to remove the amount of bone which has to be removed, and then you can go back and reposition the guide back again because the blue pins are the ones which are stabilizing the guide. The yellow pins are the ones which are telling you how much bone is removed. So we went back, removed the bone, repositioned the guide back again, and you can see in the bottom left side, the implants are placed. And after the implants are placed, and we did an immediate prosthesis for the patient. Now, Leon, let's talk about this.
On the medial prosthesis, so basically what we've done, in the same day that we send the practitioner or the oral surgeon or whoever restores this, we send them the surgical guide, fully stackable, and we send in the prosthesis. So the patient will leave right away with a smile. Now that will give us kind of an idea how much teeth does the patient show, because after doing the surgery, removing so much bone, we want everything to heal. We cannot send him just with a denture. We will load it. So we provided Dr. Reg with a type of milk prosthesis with some holes for him to reline it. So what he did an immediate loading, and he did a chair side automatically. And that's at the day of the insertion. And that's how the guy looks. So I think aesthetically, the guy was very, very happy from where he was to where he got. Now, that already gives us a lot of information. For the same day loading, yes, it looks amazing. But when I look at it, the patient's left side is falling down. So when he smiles, we could raise it up. And now, at the day of the surgery, we can already see by the amount of the bone that they reduced and everything. Now, yes, he might be numb and he might not fully smile and all that. So we keep calling him back after 2 weeks and keep evaluating it as we go. Now, that's next picture, it will be a month already in the mouth. So you see no blood, no nothing. He looks very happy. And we proceed monitoring the case to see how it's really healed. Now, tissue supported guide.
Yeah. So that was the bone supported guide where we did not have enough intracranial space, so we had to reduce the bone, but the CBCT helped us to reduce the bone volume. Now, the tissue supported guide. Now, in this case, what you're seeing right now, there's no flap raised. All the pre-planning is already done in the computer. So we had the intracranial space available. So this guy was a lucky patient because he didn't have to do any bone reduction surgery. So this is a soft tissue supported guide. We already planned everything in the computer. So this patient had 6 implants placed in the maxilla. At the same time, very similar type of prosthesis. It's actually a pink PMMA style. All the buckle is pink layered with composite. So at least it has a beautiful transition from white to pink, and patients are actually pretty happy. So you can see here right now in the next slide, while we're working with the residents, in this case, so this is surgeon Dr. Alexis Gannum working with me together. So actually we spend a lot of time with our students so that they get the best exposure while they're doing the procedures. So our program is actually a very hands-on program. We let them do a lot of work and we take a lot of pride in teaching them. And our biggest goal is to make sure that we teach them the best implant dentistry, what they can practice. So yeah, if you look at the picture at the bottom on the right side next to me, that's Dr. Salapur. He's the one. Okay, so this is the patient after, before the loading, and this is the patient after the loading is done. So patient walked in the denture, went home with an immediate loaded prosthesis. So guided surgery has been there for a quite long time. My personal exposure with guided surgery since 2005. When I joined my prosthetic program in 2008, that was still brand new. Not everybody was ready to embrace this technology. And I was a resident at that time. And that time was already, I was able to plan and design cases in 2008. And almost 13 years, Leon, I've been working on guided protocol. That time, the data was not the greatest. But now, all this year, there's so much new information is available because now there's so much data to support that. This is a very predictable treatment plan with a very accurate in terms of entry level of the implant with an accuracy of 1.2 millimeters of deviation, and the apex max is 1.4 millimeters of deviation with an angulation discrepancy of 3.5. In the beginning of 2010 and 2012, this angulation discrepancy was more compared to what we have right now. So definitely this guided surgery has definitely moved on amazingly, and now it has been embraced by everybody in many departments, and it's been a big education module in many dentists too.
So thanks God technology evolved, because if not, we would still be struggling with the dentists about the implant angulation and solving the problems. So thank you technology, thank you God.
Okay, so if you look at the studies and data, that there's not a massive deviation. So we have the abutment design. We are trying to change the interfaces of the prosthesis by having stock abutments or multi-base abutments, trying to reposition the implant platform. So all these things really help us to get a good outcome. But from planning standpoint, the accuracy of the guides have been very, very helpful. But now, yes, we talked about guided surgery guide, but still we do follow the conventional protocols of doing surgeries too. For example, in this case, when I talk about how this patient has multiple failing teeth, yes, we have followed the CBCT plan for planning the patient, but all the whole protocol has been followed using the conventional protocol. Now, for example, this is a very young man, 49-year-old. When he came to the department, all the work was done in Ukraine, and he's been in US for almost like last 10, 12 years. You can see this massive reconstruction in the maxilla, very few remaining teeth in the mandible. So all these teeth are failing because of this one reason. The whole plan was to extract all the teeth. So obviously for somebody that young, for him to sacrifice all the teeth was not that easy. So he was really had to spend time psychologically, mentally to motivate him, to tell him that this has to be extracted and we need to provide a full arch rehab to both arches. So teeth are extracted. We prepared conventional radiographic guides. Based on the radiographic guides, we did a CT scan. Dr. Gannon identified where exactly the implant's going to be. This was an open flap with conventional guides, placing the implants at the same time. But unfortunately, did not load the case in maxilla because the type of bone which is available was not ready to receive an immediate prosthesis. So we submerged those implants and we waited 6 months in the maxilla. Now, again, once we did the maxilla, the next step was to do the mandible. Now, in the mandible, patient had a cast partial denture, very few remaining teeth. So we extracted all the teeth. You can see in the top 3 slides with the prosthetics and the extracted socket. And now we created immediate denture and a radiographic guide. So once we extracted the teeth, we did a CT scan and we made measurements on the guide to see how much amount of bone reduction has to be done. So now you can see here right now in the middle picture on the top, see we identify the surgeon where exactly the bone has to be reduced. We want to make sure that at least we have 12 millimeters of space from the incisal edges of the lower anterior teeth to the bone, so that's exactly where the implant platform is going to be. So once we reduce the bone, we already have a beautiful flat foundation of the mandibular arch, and we are able to place 6 implants. And after implant surgery is completed, we place the multi-base abutment. These implants are from Straumann, and once we have these implants placed, now we already have a lab which processes a denture, and the lab already knows where these implants are going. Based on that, lab gave me the pre-existing holes in the denture. So add anything
So yes, to the pre-existing holes in dentures, usually if we do the conventional surgical guide, we open the holes the same day. So in those cases, Dr. Beck will give me a buzz a day before, say, Leon, I need you tomorrow at the lab, at the office, we'll need to do some immediate loading. I need your help. So in that day, I'll come and I'll spend 4 or 5 hours, as long as he needs. I'll be by his side, opening the holes, making sure we'll do it together, because he can focus on making sure that the patient doesn't bleed. The surgeon did his own part. He can focus on his hand. I can focus on my hand to give what the patient needs for an aesthetic smile. Now we will proceed. After Dr. Beck will start loading, he will explain a couple of steps of how he does the loading. Please.
Yeah. So basically now we are converting an existing denture to fixed provisional. Now, immediate extraction, immediate placement, and loading has been a big part of practicing dentistry in the last 4 years. So most of our patients walk in with teeth and walk out with teeth. Very rarely we send the patient with dentures unless we run into a very compromised bone. So those are the very few patients, but most of the time we load this prosthetic for the patient, especially the mandible, definitely. So what we do is, we always, when you do the loading protocols, we always work with an abutment level prosthesis rather than working with an implant level prosthesis, because we want to make sure that we bring the interface to the soft tissue height so that at least we can able to load the prosthesis. So what you see here right now, on the left side of the screen, sutures are placed. We already know where exactly the holes are. We block the, we place the temporary abutments on the multi-base abutment. We place rubber dam. You can see on the lower left side of the screen, all the implants are beautifully placed. They are sitting inside the buccal, what do you call the surface of the teeth. They're not coming in different angles. Thank God I work with some fantastic surgeons. They know what exactly they're doing. If you have a good surgeon on your side, you have a good prosthetics on your side. So that's the reason very important to communicate with the surgeon. So now we pick up the prosthesis and the patient goes home with the immediately loaded prosthesis. Now, in the meantime, patient is waiting for healing, almost 4 to 6 months, based on how complex the surgery was. And now when the patient has finished healing, patient comes back. Now we are ready to start working the final prosthetic design.
Now, the final prosthetic design can be picked up in 2 ways. We can do it in either the digital scan or the analog way. The analog way will be as we used to do with custom tray, impression copings, and we'll proceed forward. Now, is digital technologies really there? And that's what the big question is. Now, to get a full mount digital technology, yes, you can do it, but unfortunately, the process of acquiring an accurate model with a spread, so it doesn't, you have to invest in face hunters, face analysis, and it's a little bit more expensive. So in this case, we'll show you how we've done it in a conventional way, which we provided a doctor with a custom tray. We right away did a verification jig on spot with some floss and some light pure VLC material. After we've done that, the doctor puts it in the mouth, makes sure that everything is passively fitted. The idea of using two different materials for the upper and for the lower, it's color coded, makes it a lot easier. And obviously different materials have different shrinkage and it's a lot easier to handle. Now, after we do acquire the final impressions, we will proceed. Now, does digital technology, like I said before, yes, we can do it. We've done with Dr. Beck a couple of cases, but we found that they were not as precise for implants, so we always will have to go back to verification jig and all that. Now, what is the really advantage of digital scanning and intraoral?
You are disconnected. Dr. Beck, Mr. Gergov, you are disconnected. It seems that we are disconnected from Dr. Beck and Mr. Gergov. I hope we soon resume again. We are completely disconnected. Yeah, you were disconnected. Can you hear me now, Mr. Gergov? Again, you are disconnected. It seems you are disconnected. آخه حرکت هم نمیکنه تصویرشون. برای شما حرکت میکنه تصویر؟ نه.
Can you hear us?
Yeah, we are.
Sorry, we lost you there. We had the internet, we disconnected with the internet. We'll go get back right at it.
I paid the bill.
I know you did. It's because of me.
Please go on.
Here?
No.
It's flexible, you know, sometimes you are on and sometimes you are freezed. Now, oh yeah, here we have your slides.
Perfect. Dr. Beck, please explain us regarding the digital and non-digital way.
I told Leon that I paid the internet bill. So, okay, so when we talk about using a conventional data acquisition compared to traditional way, right? Because now the whole world is being really chasing digital technology. Intraoral scanning has been the biggest thing in the market right now. And I don't know how much you guys have embraced down in Iran, but definitely this part of the world has been very robust. Now, if you look at the traditional protocol, right? For example, Leon can explain the top row, what exactly is happening for you from a collab standpoint.
Spending probably 2-3 hours to prep all the teeth, packing the cords, 2 of them, making sure there is no bleeding. We acquire a beautiful polyether impression. That's Dr. Beck's impression. Actually, that's how he does them. It's very beautiful. Then we fabricate the model. After the model, we fabricate the metal. They go. Now that's the top. On the bottom, it's digital. So basically, Dr. Beck still does the same procedure of prepping the teeth, packing the cord, making sure there is no bleeding. Bleeding is a very big problem if you have intraoral scanning. And basically what we do, we eliminate all these steps of trying, pouring impression. So we don't deviate from the original scan. So we don't have lost in shrinkage of the material. We don't pour the model, which expand. Then we have to cut it. Then we have to make sure everything is passive. In using digital technology, we create a CAM and a software of the teeth. And that's the easier and the software, the kind of, it's more pleasing for the patient. So we don't have to go with so much material into their mouth.
So, an example, if you go back in the slide, Leon, you can see how we are able to overlap the preps with the diagnostic wax-ups on the teeth. So at least we already can mill the temporaries and have things ready for the patient. Now, for example, a lot of offices, we have chair-side milling units, which can provide immediate temporaries for the patient after the preparation has happened. Now, the most important thing is, a lot of times we get to ask questions. People say, okay, what are the criteria for different scanning? Because there's so many scanners in the market right now. Now, if you ask me, what's your criteria for really selecting a scanner, right? So you have to really understand what the scanner dimensions are. How big is the scanner? Are you planning to have an in-office milling? Would you have somebody like Leon in your office who's going to help you to provide you lab support? What kind of size of the wand is? Like how big is the wand that goes in the patient's mouth, right? How expensive to maintain this is, how much yearly annual subscription we have for the software. Now, and how easy to adapt and the learning curve, right?
Learning curve is a very important thing in intraoral scanning. You don't want to be the only one that does it, because if you're the only one who knows how to do it, you want to teach your assistant. Sometimes, if your assistant knows how to scan, 95% of the job is done. They scan the bite, they scan the antagonist. You just need to scan your prep, which a lot of help in saving chair time.
So these are some of the things what we follow when you look for scan. Now, when we talk about conventional versus intraoral scanning, now you can see in both slides on the top and bottom, when you have a digital protocol where you, on the top, you're seeing where we have combination of teeth and implant. Because with implants, you're not placing any impression copings, but these are specialized terms called scan bodies. So instead of using a conventional impression coping, you place the scan bodies. The soft can read the scan body and identify how exactly where this implant is placed. So now it can create a virtual model for you, and you can print this model and you can place the digital lab analogs into the model, and then probably you can explain how the workflow.
By adding this, so basically Dr. Beck put the intraoral scan bodies inside the implants. By scanning them, the computer creates a matrix of where I receive the file, I align the DME digital implant model into the scanner. When I align it, the model creates the matrix. So when I print it, I can actually fit a perfectly fitting lab analog inside. Now, all this procedure saves a lot of time. You don't really need to go into verification jigs and all that. Even though they're important for full mouth reconstructions, for single implant units, the diversity of the implants is in 2 microns. Now, if you do single units, 2 microns is not the end of the world. It's actually fits well and it feels good. When you do still full mouth, it's still 2 microns, it would be a lot. So that's why we do verification. In the next slide, we're going to get to the CAD/CAM restorative prosthesis that we've been doing for the last 5-6 years with Dr. Beck.
So finally, the last part of the presentation, we're going to talk about how we have embraced CAD/CAM technology, not only for scanning and designing, but also for final prosthetic restoration. But when you have a patient who has to need a full arch reconstruction, there are 4 important parameters you have to take into consideration. One is the bone, the lip, how is the smile line of the patient, and the interface of the prosthesis with the implant. Now, these 4 definitely dictate where exactly your implant design and the prosthetic design and the material choice is going to be.
And how do we do that? We do with one most important thing, is diagnostic wax-up is a must. Don't try to save on it. This is something that will help you to, first of all, introduce the case to the patients, and that will be the blueprint for your whole path of success to the final prosthesis. So the next slide, basically what I've done, it's the same diagnostic wax-up. This is how we design bars. So it's the blueprint for my bar to know the dimension. Now, in this case, I'll show you the next slide. It's a zirconia with metal support. So class number
Again, you are freeze. Mr. Gergov. Oh, you are freeze, Mr. Gergov. Please pay the internet bill. You are freeze, Mr. Gergov. Dr. Beg, you are freeze.
there for
Hello.
sorry, we lost you again. Just the
we can
not
hear
very
you.
stable here.
Good.
Can you
This is
hear us?
my fault. Yeah. Okay.
Can you hear us?
Yeah. Now it's okay.
Perfect.
So last few more slides, Doc.
Yes.
After that, we'll be done. So basically, what I'm trying to explain is we kind of classified patients in 4 different categories. So class 1 is, this is the patient with 15 millimeters of physical space we have. Patient has a lot of bone loss. We have beautiful interface from the occlusal plane to the crest of the ridge. Patient has a low smile line, and this is the best patient any prosthodontist can dream of. So these are the easiest patient to manage.
And that's the cases that we love the most, because for the lab, when we do the pink and the white, we basically can do whatever. We can do a bar with zirconia. We can support the zirconia fully with a nice bar that we gold plated. In the lab, doesn't matter which bar it is, we always gold plated. Now, after we've done that,
I can. There was a sound.
yeah. So that would be the final result of that case. So basically what we've done, you can see that this is the class 1, where we have a lot of room. So we have to restore the pink, we have to restore the white, and in the end, that looks the result. This is a full contour zirconia with a facial layering in the front with all the certification of Namelon, opals, effects, white, and that's how it looks. Now on the next slide, that would be the class 2. In class 2, it's mid to moderate bone loss.
So you saw the beautiful ceramic work by Leon. So if you have any beautiful cases, guys, in Tehran, you can count on this guy. You can send him here from.
They have a basic ceramics over there. One of the best around designs there.
Okay. So class 2 is a mild to moderate loss. So now this patient is something which is also not a bad case. So it still is workable, but patient also has a low smile line. Lip support is not the biggest consideration, but the prosthetic gingiva is mandatory because the size of the shape, the space is shrinking. Now you can see this red round interface of pink, what you're seeing on the right side of the screen. That means that's the very minimal amount of space you have. Now, in this kind of situation, the design of the prosthesis can change.
When the design of prosthesis of that case change, what we have to do, we still use kind of the same case, which means that in that case, what we've done, we can do the restoration with tight bases or regular bar. Now, in that case, it looks the same. The one on the left is a little bit different. The prosthesis of the gingiva will be just a little bit shorter. We still have a full length of the teeth. And you can see at the lower picture that what we've done, we have the bar, we have the screws, we have all the prosthesis. But in the right side of the pictures, you see the double structured bar because we don't have a lot of room, but we don't want to have occlusal screws because some patients don't want to have any hole occlusally, so we've done lateral screws. In that case, there is another picture of the case. Class 3 case presented. The patient did not show a lot of pain. The distance from the tissue was from the arch and the bone was not as much as in the first case. So what we do with shrinkage, and when you can see here, the guy, you can't even first of all say that he's a class 3. That was just a hybrid dentures, screw retained permanently in the mouth. Till next time. Now, on the right side picture, you can see all the procedures of regular bar, sandblasted bar, or pink opaque, and the teeth themselves. Now, in the next picture, I'll show you the Rolls Royce of dentistry, which a lot of people keep asking, oh, why, what, and when do you do it? This is for cases that you do have a lot of room, and you can do single crowns. The advantage of this case is that if something breaks, that would be class 1, yes. If something breaks, you can change one tooth at a time, not all of them. The only thing is with that case is basically you restore the whole tooth from single crowns. A lot of work, a lot of pain, but in the end, the result looks amazing. That would be another case where tissue was just minimized there. So we've done on-tie bases. We didn't use any bar because there was a big chunk of zirconia, a big amount, and that's how it looked in the mouth. There is the layering facially. This is a regular overall converted bar with screw retained denture teeth, and that's how it looked in the mouth as well. Now, class 3, and this is the class that we basically don't really enjoy doing because it's the hardest, but sometimes we still do get them, and we'll show you the pictures. Now, Dr. Beck, please explain about class 3.
So basically, this is where the challenge becomes very obvious for you, because now you have 9 millimeters of space, 8 millimeters of space. There's not enough bone loss. Now, these are the cases where you end up doing some kind of bone reduction. Either you try to squeeze the prosthetic design with the limited space what you have, or you can recommend your surgeon, like my previous case where we did a bone reduction guide and we had to reduce the bone volume to compensate and modify a class 3 patient to a class 1 or class 2. So here, because of the limited space, obviously your interface of the prosthesis and materials can change.
Now, this is the patient, sometimes even if you do the bone reduction and you do all of it, after you even reduce so much bone, the patient high lip line is coming all the way to the nose. In that case, the next case that we show you, we could not remove enough bone, so we basically removed all the teeth. And in that case, you can see that the teeth looks like natural teeth. We scallop the tissue, and what happened in the end is like, even though we've done a bone reduction and everything, the patient smiles and you can see all the tissue on the top. Now, class 4, and that's the undesirable one because that will cause a removable prosthesis.
So in these are the patients where they have a high gummy smile line. Now, yes, there is very minimal intraocclusal space, but when this, because of the hyper mobility of the upper lip or highness of because of the gumminess of the smile, you cannot hide the prosthetic and the implant interface. So for these kind of cases, it's going to be very challenging for you to have a patient do a fixed style of prosthetics.
So what we do in that case, we do a removable style of prosthetic where you can do either double structure or single structure. So in that case, we've done an overdenture, we put a bar with some locators, and we've done some nice denture teeth. In those cases, you have to make them removable because they're not very cleansable and not very hygienic cases. Now, if you make them fixed and the patient cannot clean, within 4 to 5 years, he's going to lose the whole prosthesis. That's another case that we've just done with Dr. Beck. Around a month ago, we decided to go with an upper and lower dentures over bars. So you can see how the bars are already super gingival. Now, when he smiles, all the bars is up there. And conclusion, Dr. Beck, please.
So kind of we've been spent a lot of time today talking about different classification of patients and why these things can be quite challenging. So as I said, the biggest factor what really helps you to do it, you have a proper diagnosis of the patient. Make sure that you don't have the same yardstick for every patient. Every patient is different. Every patient's treatment plan is different. Every patient's criteria of selection is different. So you have to make sure that you have a full knowledge of bone volume, smile line, lips support, gingival prosthesis requirement, because all these things are going to be a very important role. They're going to dictate how the whole plan is going to be. Yes, lip support, you have to make a decision whether need a lip support or not. So that's purely based on the case specific. Okay. And second thing is tooth proportions. Again, as I said in the beginning, doesn't matter you do full arch rehab. Keep in mind the one thing I was taught when I was a resident was a complete denture is also a full mouth rehab. A lot of times people think that complete denture is a boring thing. I don't think we should show a lot of interest. That's not true. A complete denture is a very important milestone when you're doing implant restoration. So guys, I know some of your residents in the program, please don't undermine the value of doing denture. So I think if you really spend a lot of time understanding complete denture, you can do all these fixed rehab cases with great ease, okay? So that's the reason tooth position is proportions of the prosthetics are very important, and understanding the basics of dentures is very, very critical as well. And finally, from a standpoint, the class 1, class 2 are manageable cases, but the class 3 and 4 can become quite challenging. And when you have a case of a class 4, you really have to sit down, talk to the patient and your surgeon to see what your limitations are, what are the surgical limitations, prosthetic limitations, what limitation the lab gonna have when they are giving you the final restoration. So, so to treat these class 3 and class 4 patients, you really have to have a great knowledge. So again, a thorough knowledge and the application of facial aesthetics and complete denture principles is very, very important. I cannot emphasize this enough. And as I said, this thing has to be really taken into consideration with every different case. Yes, prosthodontics is not cheap. Trust me, when patients walk through my office, when I give them treatment plans and when they leave my door, they're not very happy because they know that this thing is going to cost money. But keep in mind, we are not here to do business. We are here to educate our patients, give them the best possible care. Listen, our job is to educate them. Help them be the judge of making the decisions, you know. And we document our cases so much because we always can show the patient what the value we brought in others' life. So this will really help you for the future patients to understand what we have done in the past, because you document your cases, you show your future patient that this is what we did with other patients. We can do the same thing for you too. I think that's how you keep on recruiting patients and help them to achieve the prosthodontic goal. So finally, everybody, thank you so much for being very patient. It's almost 1:45 in Toronto, and yeah, we just took this picture.
Yeah, we just took it right now. Before we got extremely embracing the conversation, if anyone have any questions, please, we're right here. We would have the emails as well online. If we can help you somehow, we would be more than happy. Just remember, in the end, it is a teamwork, and the more people you get involved, the periodontist, the GP, the lab technician, which is important, altogether you can give something back to them.
Thank you so much. Nice lecture. It was very informative. Thank you for being with us at your midnight. And I have some questions, but unfortunately, we should go for our next. Actually, we are 15 minutes behind our timetable, but may I ask two questions, two very short questions. First of all, you have metal substructures. You have put, I think, zirconia over it. What was the kind of metal? Was it titanium?
No, when I do, because it's already heavy, zirconia is very heavy, it's very chunky. Usually I do it from chrome cobalt, which is a little bit lighter than titanium. And
it's better for applying pink porcelain or covering pink porcelain over it.
It's mostly when we have a little bit cantilever, and cantilever, there is no implants at the back. Usually I'll use the bar. To put pink, I can do either or. It's no problem. The only reason why do I do the bar, it's because when you have posterior teeth, a lot of them, they pay a lot of money, but they don't have the implants. They don't have enough bone in the posterior region. So what do? I extend the bar, which is metal. It's strong because zirconia would break. And throughout time, you know, after 4 to 5 years, zirconia in the mouth, it's deteriorating. It's getting weaker from the saliva. Type 3, type 4 zirconias, they get weaker. As we know, Jürgen Steger, it's one of the creators of Zirconzan. They said that the zirconia within 4 to 5 years loses the strength of it, and it gets weaker, and then you get fractures on the thigh bases. When you have a bigger surface of bar, you have actually more friction, and it stays longer in the mouth.
My question actually was about the metal substructure. The other question that I have, it was you have CBCT from the denture of the patient. Of course, you had some markers that were radiopac. What about the denture? How do you make it visible inside the CBCT? Did you do anything especially for this one?
Special material that's called
Yeah, so we have what we do is in spite of placing this,
beside the landmark, she said the white one.
so they talk about the white material,
The white material, right?
barium sulfate.
Barium sulfate, yes. So barium sulfate is a material that you buy from another lab division. You pour it, and then when you do the radiopac, you can see all the teeth. Now there is an other way to do it. You can use gutta percha. You can take gutta percha, make a powder, and put it in each tooth.
So you paint all of the denture with barium sulfate?
I do the teeth.
Or you are,
Only the teeth are made with barium sulfate.
I pour it as it becomes as an acrylic. I pour it, only the teeth, and then the rest I do clear. Okay?
Okay, so there are some questions from the chats. In most cases, you did full.
Yeah, my email is bobbybig@gmail.com. Dr. Farid is going to give it to you. Feel free to send email. I'll be very happy to answer. I don't want to hold back the next speaker. So I'm always here to help you and answer questions. Okay, so.
Okay, so I will ask our the people who ask some question to email it to you. Okay.
Yes, please. We would be more than happy to answer it. And if somebody wants to do Skype or Facebook call, we would be more than happy to help.
Okay, thank you so much. Thank you
so much for having us. We wish you a wonderful day. Good luck to all the participants. Thank you.
See you sometime.
Hopefully soon. Thank you so much.
Would you please write your email to the chat box? Dr. Beg, write your email to the chat box. My colleague, Dr. Saad.
All right, good to see. Good to see you. Thank you so much for a wonderful lecture. So I have just one question. Where did you get the last picture? The last slide was the best one.
We just basically did it from the computer just before we finished the lecture. Thank you, guys. Thank you so much. Thank you so much for having us. It was really a pleasure for us. And we'll see you soon, hopefully.
Hopefully. Thank you so much again.
Good night. Hey, good morning. Ciao.
Bye.
Bye.
All right. All right. So let's move on with the next lecturer, which is Dr. Siadat. She graduated from Tehran Dental School, and since her graduation from Advanced Prosthodontics in Tehran Dental School, she was a faculty member of here, and she's a full professor of prosthodontics and fellowship in implant prosto, and also she got another fellowship in digital CAD/CAM dentistry. And her topic for us today is a CAD/CAM restoration for endodontically treated teeth. So please like to see how that move on. Thank you. All right, we see the first slide.
Hello, everyone. I am Dr. Ziadat. It's my pleasure that I was invited in this webinar. And as you know, I will speak about CAD/CAM restoration of endodontical treatment. We can discuss about it and share our experience. And in the end of the webinar, if is there any question, it will be my appreciation to answer your question. When a tooth with this remain very healthy structure of the teeth after the endodontical treatment, forward the teeth into the full prep of this remaining structure of the teeth and get a post and a full crown restoration is not recommended. In this situation, make a good decision for this kind of the teeth will be better, and it's better than you go toward to the endocrown restoration. As you see in this slide, we have very intact structure of the teeth around the tooth, and we can save them with the making a good decision. We have some disadvantages with the routine cemented post and crown. You know, placing the post requiring additional operative procedures, and you have to pay more time and cost, and the preparation of the teeth accommodate the post entail removal additional to the structure, and the post can complicate or preclude future endodontical retreatment that may be necessary. And we have some limitation for the using the intraradicular post. Sometimes our root canals are calcified, or we have the narrow canals with the molars of the teeth, and we have some fracture of the instrument in the roots. Then we can't make a very good and a standard post with this kind of restoration. In this situation, it's better than to go to the endocrown restoration. The endocrown restoration first used by Bindel and her co-work in 1999, and it's the only restoration on endodontical treatment teeth, and they are an additive single partial restoration. They are monolithic ceramic restoration, and they encourage in the pulp chamber, and they are more conservative than the full post and the full crown. We have some indication for this kind of the treatment plan. When the crown height space are very limited, and we can't get the standard restoration with the front height standard, and we don't have the retention with the cement, this restoration has the indication. In molars or premolars with calcified canal or narrow canal, you can use this restoration, and but you have to have about 1/3 of the crown structures. If you don't have this amount of the structure of the teeth, you can't follow this kind of the restoration. As you see at this slide, we have about 1/3 of the healthy and intact structure of the teeth, about 2 millimeters buccal height, and about 2 millimeters buccal or lingual, and the proximal thickness of the healthy intact structure of the teeth. The longevity and effectiveness of this kind of the treatment plan was approved by the articles, especially for the molars, but there is not enough in the articles about the premolars. Then you have to caution if you need to use this kind of the restoration in the premolar teeth. The survival rate of this kind of the restoration is about 99%, and success rate of it is about 90% in the molar teeth. But we have some contraindication with the endocrown when our patient have functional habit is not a good choice for this kind of the restoration. And as you know, this kind of the restoration is according to the bonding. Then when we don't have the enough isolation, then you can't use this kind of the restoration. And as I told you, less than 3 millimeters depth in pulp chamber is not recommended to use this kind of restoration. Another advantages of this restoration is there are conservative preparation, and you don't need to crown lengthening because you don't need to fold. When you don't need to fold, then you didn't do any operation of the crown lengthening. Then your patient didn't need to pay more time and more economical payments. And when your patient has to pass this operation treatment plan, he has to suffer from maybe sensitivity of adjacent teeth and loss the bone and crown ratio may be compromised. And it's not good for you and your patient. Then when you don't need the fold, it will be very good for you and your patient. In this restoration, the gingiva is far from the finish line is far from the gingiva and more surrounded of the teeth. Then gingiva is very healthy and you don't have any irritation on it. This kind of restoration is very fast. Delivery of it is very fast. In 1 or 2 visit restoration, in 2 visit appointment, you can deliver it to the patient. If you have equipment of the CAD/CAM technology in your office, you can deliver it in 1 visit. And if you don't worry about it, you can deliver it in 2 sessions according your cooperation with your lab. But we have some disadvantages for this kind of restoration. The risk of debonding is this kind of restoration is high if you have the premature occlusal contact or poor function for the patient. And when you don't have enough isolation for bonding, and in this situation, risk of debonding is increased. And if you don't follow the rules of the thickness of surrounding of the healthy teeth, the risk of fracture will be increased. And according according, as you know, you have to have 1/3 of the sound structure, and when you don't have enough of the structure or missing it, you can't use it for the endocrown. And which kind of the ceramic recommended for this kind of the restoration? We have the broad range of the ceramic, and you can select one of them. But none of them is not good. For example, with the zirconia oxide ceramic, you can't get enough bonding for the endocrown, and you know The endocrown is according the mechanical and chemical bonding. And when you don't have enough bonding with the zirconia, it's not recommended for this kind of the restoration. Amphosphatic porcelain is not very good because the flexural strength of it is not very high. And the glass ceramic, the glass ceramics are very good for this kind of the restoration. The famous of them is the IPSC Max. IPSC Max is the lithium disilicate glass ceramic, and it's very good material. It's have the range of translucency, shade, and size, and the aesthetic of it is very high, and bonding of it with the tooth will be very good. According to catalog, you have the range of translucency, high translucency, medium translucency, and low translucency with different shade and size, and you can select according the fit of the color fit of the patient. And this kind of the ceramic has enough fracture strength near to 550 and 74 megapascal, and it will be good for the single or 3-unit situation. And it's very good and useful for the conservative dentistry, and it's available in different lab methods and trainings. Then all of the technicians can use this kind of the ceramic. This kind of the ceramic is the blue block according to the manufacturer. They are in CAD/CAM or press fit, and most of the technicians use press fit ingot of it. It's blue block and partially crystallized before the complete crystallization. In this situation, the flexural strength of it is 140 megapascal, and after complete crystallization in the vacuum at the furnace at 850 degrees centigrade, the fracture strength of it gain up to 574 megapascal with the optimum translucency and aesthetic. And after that, you can stain it, and it's ready for the cementation. Another ceramic that is useful for this kind of restoration is zirconia reinforced lithium silicate that are like self-radu. The self-radu block are introduced as a ZLS, and the crystallization of them are complete. If you don't glaze it, the flexural strength of it is about 210 megapascal, and after glazing in the furnace, it gains up to 370. The technique of it can be wet firing technique and dry firing technique. Both of them go to the furnace. In wet technique, you can use stain and glaze, and after that fire and deliver the restoration. But in dry firing technique, you use only polishing, and after that fire and stick. This kind of the ceramic is very good for the aesthetic restoration, and the producer claims that marginal integrity of this kind of the restoration is very high. As you see in the picture, you can see the marginal integrity when it will be very thin, it can be very good. We have some rules for the preparation of endocrown. Then we can check some of them together. When you have the molar teeth, you have to 6-degree divergence the preparation in the axial wall from the pulp chamber up to occlusal side. If you have more divergency, you have to prep more teeth, and then you left some intact teeth. Then 6-degree divergency is very good and enough for sitting the restoration and remain good structure surrounded of the tooth. As we know, we have some undercuts in the orifice of endodontical canal, and then you have to ignore this kind of the undercut. If you want omit all of this undercut, you have to increase your divergency and remove the intact teeth. As you see, we have some undercut in the orifice, then please omit them. But in the surrounded of the preparation of the teeth, don't ignore, omit the undercut, because this undercut may be interfered with the sitting of the endocrown. Then in the surrounding of the teeth undercut, we have to eliminate them. And it's better than you have 3 millimeters depth in endodontical pulp chamber. If you don't have this amount of the pulp chamber, then maybe you don't have enough mechanical retention, and may you need re-cement again and again your endocrown. Then please ensure that you have enough depth in the endodontical pulp chamber. And as I told before that, we need 2 millimeters sound dental shoulder around the teeth. At least in buccal and lingual you need them, and if you have in the proximal side, it will be better. And don't forget, omit the unsupported enamel in the deep margin and around the tooth. Around all of the sharp angle of the edge, any sharp angle can interfere with the sitting of the endocrown. In the pulp chamber, we have the convex cavity, and it can be good for the retention, for the mechanical retention, and it can increase the surface for getting the bonding. Then you don't need adding any glass ionomer or composite in the floor of the pulp chamber. And the occlusal side, you need 2 millimeters reduction for ensuring the strength of the endocrown. And the simple design preparation is better because the complication design of preparation can complicate your prepping and your sitting. Then please check all of your preparation will be simple. And in this kind of a restoration, we don't need any ferrule. And if you want to have the ferrule, you need to increase your preparation, and may you have a very thin structure of the teeth in the near adjustment of the ferrule, and may be broken, and it's may interference with the sitting of the restoration, that then we don't need any ferrule. After complete the preparation, don't forget polishing your preparation. It can be good taking an insertion, and after that planning and deliver the good restoration and the polishing preparation. According to the article that published on JP 2019, they show the ferrule can significantly greater failure in the endocrown. If summarize very fastly the rules of the preparation, we can check some of them. The preparation is in 90-degree by joint margin, and a reduction of the cast height is near 2 to 3 millimeters, and the divergence of the pulp chamber preparation is about 6-degree tapering, and orifice undercuts are okay, and you ignore all of them, but the undercut surrounding of the tooth must be omitting. And you don't need engage into the canal because it may wedging on the tooth and may reduce fracture. And no angle or edge shoulder preparation, and you need rounded all of the edge, and enamel wall less than 2 millimeters thick should be removed, and the depth of the cavity should be at least 3 millimeters in the pulp chamber. For getting a good a good impression, you need recognition of the finish line. For retraction and recognition of the finish line, you have some methods. One of the famous of them are using retraction cord. You have some retraction cord with different thickness according to your gingiva. You can select one of them. And the laser diode is one of the good device. If you have this equipment, you can use it. And silicone burr can be useful, and electrosurgery cautery can useful for the retraction, but you have to know if you use coutering, may sometimes may you have the recession of the gingiva. And the simple and very easily method is using a silicone paste. You can inject this kind of the silicone paste in the pregingival sulcus. Some of them are very famous, expensive and astringent, and you can use them. After 3 seconds, you can recognize the finish line very easily. After that, you need to make a good impression. If you have the digital equipment, you can make a digital impression. If you don't have, you can get a conventional impression. Not important. If you have the digital equipment, you can use the device for scanning of the teeth. A quarter is okay. You don't need a scan full of arch. Half of them can be okay. And after that, when you complete your scanning, you can go for the planning of the restoration. If you don't have this equipment, you can get a good impression with an additional silicone with the putty and the wash of them as the fixed treatment plan. And after that, your lab can scan your impression or your cast. And in both of manner, the information going to the software, and at the software, you can plan the jaw, the patient jaw, and after that, draw the margin as the finish line. You can draw very exactly and fast, and after that, you insertion the axis, the path of insertion of the restoration, and you define the parameters of the restoration, and you can select your restoration from the catalog of the software and check the occlusal and proximal contact and set into the CAD/CAM block very easily. And after that, you can go for the preparation of it in the CAM device very easily. It's an pixel device for clinical preparation of the CAD/CAM blocks. And with this device, you can deliver restoration involved with dentistry very fast, very exact, and with the complete aesthetic. This device can prep the block about 7 to 10 minutes according your ceramic kind. And after complete the restoration, you can have your restoration. If you prep the Emacs block, you have the blue block of the restoration, and you need complete crystallization of it in the furnace. And after that, you have your crown, and you can stain and glaze it. And your restoration can be ready for the cementation. As you see, all of you can check at the software. And it can be very good in the setting and in aesthetic. And after that, you need cementation of this kind of the restoration according the resin cement. The best resin cement that recommended for this kind of restoration is dual cure restoration, because the thickness of the endocrown is high, and if you use light cure cement, the curing not enough in the depth of the pulp chamber, then the using of dual cure cement can be better. If you use Emacs ceramic, it's better you use hydrochloric acid gel for 20 seconds, and if you use self-radu, it's better 30 seconds hydrochloric acid gel for etching the ceramic, the side of the sitting into the tooth, not other part of them. And after that, rinse and dry. Some of articles recommend that using phosphoric acid for removing the excess salt from the ceramic. If you use it, you can use it for 3 seconds, and after that, rinse and dry. And you can use the porcelain bond for increase the bonding. And your teeth, for teeth, you need using the phosphoric acid and rinse and dry, and using the bonding. If you use the Panavia, you can use the primer A and B mixed together and use it into the teeth. And after that, inject your cement into the pulp chamber and sitting your endocrown completely. Ensure the sitting of it is correctly, and excess cement was passed. And about 3 to 5 seconds curing. After that, you can remove excess cement, and it can be easily for removing the excess cement. After removing the excess cement, it's better than using the dental floss for checking the proximal side and removing the excess cement. As you see in the premolars, you can use this kind of restoration, very conservative, but in this case, you need to have a very good color matching, because if you don't have the color matching in the smile line of the patient, you can see the line of the cementation. And this kind of restoration in several tips. Thank you for your attention in this webinar. If you have any question about the endocrown or ceramics about that, or CAD/CAM about that, or anything else.
Thank you, Dr. Siada. Thank you so much for your very nice presentation. And thank you for accepting our invitation. So let's see if there is any question. Dr. Siadat, can you hear me?
Yeah. I hear you.
Hello, Dr. Siadat.
Hello.
Thank you for your nice presentation.
Thanks for your attention.
Okay, so if you don't mind, we go to the next lecture, Dr. Sadaqpour. No.
Any questions coming up from audience?
No.
No question.
There is no question.
All right, thank you so much for wonderful presentation. We're going to move on for the next presentation by a couple of minutes. Thank you so much.
A couple of seconds. Okay. And so we will have a very short clip, and then we will go on with the next lecture. That is Dr. Sadaqpour. I ask him, please introduce yourself, because he didn't answer. First, introduce yourself. Oh, I must introduce you. Later, I introduce you.
Yeah, I go over there. I do presentation from the other computer. So give us just a minute
for us to introduce him. Okay, Dr. Sadaqpour, please, the stage is yours. Please tell everyone everything you want to introduce yourself, and please go on with your lecture. Thank you so much. Can you hear me, Dr. Sadaqpour?
Good morning, everybody. Sorry,
please go on.
This is Dr. Sadaqpour, and a faculty member of Tehran University Medical Science School of Dentistry. And it's my pleasure having this webinar with our colleagues. So the topic, as you see, is cement and cementation for CAD/CAM restorations. The objective of lecture would be a short introduction to indirect restorations. I describe cementing, luting, and bonding, then categorize the dental cements. We go over a short definition of tooth preparation. Yesterday I had Dr. Mustafa's lecture regarding tooth preparation, so I go over just 2 slides. And then I have some recommendation for dental cements, clinical tips. And at the end, I will show you a couple of cases. All right, as the population age, the need for dental restoration increased. However, dental restorations can be direct or indirect restoration. These are, we call them direct restoration. And whatever we make impression through conventional impression or oral scanner, and we send it to the lab. So we call these indirect restoration.
Excuse me, Dr. Sadaqpour, would you please speak up?
In the office, or the lab technician make it in the laboratory. So these indirect restorations.
Would you please speak up?
First of all, it should be durable, and correct. and aesthetically meet their patient expectations. So, metal ceramic restorations have been in the market for a while. Uh, this type of restoration came from the innovation by Mr. Taggart. He innovated this uh, casting in 1907 by making a wax pattern, and he cast this wax pattern with gold restoration. And since almost a century ago, we have this type of indirect restoration in dental field. So we can restore the crown that is damaged and lost part of the construction. So after a while, the scientists, the chemists, they were able to bond the porcelain and the metal framework. And then by uh, aging, people, they ask for more beautiful and aesthetically highly demand restorations. So we switched to all ceramic restorations, which is an important part of contemporary dentistry. So, good. So let's describe the definition of cementing, luting, and bonding. Luting refers to the placement of material between a restoration and tooth that uses micromechanical retention to hold the two surfaces together. And bonding refers to a chemical and/or physical interaction that occurs to both the restoration and the tooth. And cement is a generic term for joining material that provides adhesion and/or micromechanical retention between two surfaces, typically prostheses and the tooth. So any dental cement should perform the job of holding an indirect restoration in place for an indefinite period. So let's go over adhesive and conventional or non-adhesive cements. Adhesive cements, including the categories of adhesive resin cements and self-adhesive resin cements, rely on both micromechanical retention and chemical bonding. But conventional cements, also known as non-adhesive cements, principally rely on micromechanical retention provided by a luting agent. Let's go over the non-adhesive cements. We are all familiar with zinc phosphate cement. It has been in the dental field for almost a century, from the beginning of the gold crown restorations innovated by Dr. Taggart in 1907. So we see these type of gold restoration lasting almost for 40 years in the patient's mouth. We see the picture in the articles, 45 years old. This type of cement works very well, and still I believe on it, and I use it for cementing the casting post. The next non-adhesive cement is zinc polycarboxylate cement. This type of cement, I do remember when I was at dental school, my faculty told me the zinc phosphate is good for the endodontically treated teeth, and zinc polycarboxylate is fit for the white teeth. But now, with my knowledge now, I just use it as a long-term provisional cement. The other conventional cement is glass ionomer cement, which is very common here. The companies claim that it has a long-term fluoride release. But I don't know, when we make it crown and the margin should be tweaked and the cement shouldn't go above 25 microns, how much fluoride it does release. But that's the way that we promote, and the company claim that. The last non-adhesive cements, which is resin modified glass ionomer, are designed to overcome the two main weaknesses of conventional glass ionomer cement: sensitivity to early moisture contamination and high solubility. Let's move on the adhesive cements. Adhesive resin cements are based on methacrylate modified from composite resin and set through polymerization rather than acid-base reaction. They're excellent choice when there are concerns about retention for aesthetic restorations made from glass ceramic or composite resins. All right, the self-adhesive resin cements. This latest innovation, providing the ease of use associated with glass ionomer and resin-modified glass ionomer cells, but with higher strength, improved aesthetic, and their dual cure. These type of cements provided in three categories. They can All right, sorry for disconnection. We had some issue with the internet here. So let's move on with the rest of the presentation. So as I was saying, we have two different type of setting. So which we have light cure cements, which is, you see on the left side, we have different type of light cure cements available in the market. Relay X veneer from 3M company. We have Variolink veneer from Ivoclar. We have Calibra veneer from Dentsply Sirona. And we do have GSM veneer from GC company. And on the other hand, we have some dual cures adhesive resin cements like NX3 Nexus from Care, Calibra Universal from Dentsply, GSM1 from GC company, Relay X Arc from 3M company, and Variolink. But remember, dual cure resin cements, they contain amine co-initiator, which it comes with yellowing effect. So they're not fit for the ceramic veneers. And on the other hand, if we have a dual curing cement, which from the beginning, the setting starts, so they may limit amount of working time. So making the right choice when choosing a dental cement, the most important factor to consider is the restorative material and preparation is retentive or non-retentive. As far as preparation, we are all familiar with the 5 rules Dr. Schillenberg provided for us. I go over the second one, which is retention and resistance. According to Kaufman, he had an article almost 60 years ago, and he described the factors that provide retention for us. The first one is length of opposing wall, and the second one is the tapering of opposing wall. These two are the major factors they provide retention. You see here different type of finishing lines. We began our indirect restoration with the chamfer finishing line 100 years ago, and now again with the full serum restorations. We ended up to shoulder, modified shoulder, and again chamfer. So let's see which type of preparation bring enough retention for us. If the height of the axial wall is above or equal to 4 millimeter and the tapering is equal or below 20 degrees, that would call a retentive preparations. And if we have a abutment height less than 4 millimeter and the tapering is above 20 degrees, that would be called a non-retentive preparations. So by these definitions, I would ask you, should I cement or bond? So let's go over the cementing part. When I have a retentive preparation, like the picture you see here, I can select glass ionomer or resin modified glass ionomer cement that offers the best balance of ease of use, speed, and tooth protection. Next candidate for cementation, when isolation is not possible. So again, I choose the conventional cement, non-adhesive cements, which is glass ionomer and resin modified glass ionomer. Again, I do have a retentive preparation. As far as aesthetic, it's moderate aesthetic knee bands, so I can select glass ionomer or resin modified glass ionomer, which is proper for this type of restoration. And again, there are patients with special needs. We select glass ionomer or resin modified glass ionomer cements for high caries risk and geriatric patients. Now move on the preparation which they're not retentive. So in this situation, we go with the adhesive resin cement or self-adhesive cement with tooth primer in this situation. Next option for bonding, isolation is possible and the retention is not enough. So I go for a self-adhesive or adhesive resin cement with a dry working field. The other option, which is candidate for bonding, the high aesthetic needed, we need the maximum retention. So we go for the self-adhesive or adhesive resin cement in this situation. And at the end, the cases that we do, it's a part of our prosthodontics office, the veneers, the ceramic veneers. These type of restorations, they need the maximum retention. So the family of adhesive resin cements or self-adhesive resin cements with tooth priming would be the choice for this type of restoration. So now I classify the resin cements or adhesive cements to 3 categories. First group is aesthetic resin cements. They need etching for, we can go by self-etching or total etching for the dentin structure. And then we need a primer or sealant to adhere to the ceramic surface. They come in dual or light cure and they have highest bond strength. The second one, adhesive resin cements. These type of cements, they do provide primer on the tooth structure and they require sealant and the restoration. And they come in dual or light cure. And the last one is self-adhesive resin cements. They are self-etch, no phosphoric acid or no priming, and it can be directly bond to alumina or zirconia. Again, they come in dual or light hue. Let's go over the cement that they are available in the market of Iran. We have plenty of cement here. You see the pictures from Calibra, from Sirona Dentsply to Choice 2 from Bisto Company, and Panavia V5 from Curare. These 3 are my favorite cements when I go for the aesthetic restorations. Let's go over adhesive resin cements. You see the variety of options that we have here. We have Panavia F2, we have Panavia 21, which is a little bit old. We have Calibra Serum from Dentsply Sirona. we do have Relay X Arc from 3M and GSM Link Force from GC Company. The difference between Panavia F2 and Panavia 21, they're the same category, but Panavia F2 is a dual cure which release fluoride, but Panavia 21 is a self-cure cement. All right, let's go over self-adhesive resin cements. We have variety of cements that you see here. We do have GSM Linkase, we do have Calibra Universal. They're very easy to use, and there are options for non-retentive restorations. If audience have any question, I'm more than happy to answer your question while we're talking, although we are a little bit late, but let's move on. I have a couple of cases to show it to you. This lady came to my office like 5-6 years ago. You see how the teeth are worn down, and you see the maximum intercuspation position. She was at the beginning happy with the appearance of the teeth, but when I described her how the teeth are worn down, and when we draw a line from the canine tips and you see a kind of reverse smile, it's not proper and it's like aging and the people doesn't look nice. So what we did, I didn't have enough room for the porcelain because we have a kind of extrusion on the mandibular anterior sextant. So usually I go for just one arch at a time, but for this situation, I have to make some room for the veneers on the maxillary anterior sextant. So what I did preparation. I went for the impression, packing cord, and then make the impression. So the impression had been made. After a couple of days, we planned for the maxillary mandibular arch, and I did drilling and grinding and preparing the teeth, packing cord. As you see, the cord is number 1 from Ultradent. It's a kind of thick for this anterior sextant, but that's why I didn't pack it completely to the sulcus. So we made the impression and I sent both together to the lab. So this is the final restoration. You see, I made enough room. I compensate for the reverse smile, and the patient was really happy when she saw the pictures from beginning to the point that we reached now. She was so happy and she couldn't believe how ugly were the teeth at that time. The cementation, the choice at that time was Panavia F2, and it's the best choice for feldspathic veneers. This is a guy, he came to my office. He used to live in New York City. He had gone to a lot of offices. He was familiar with the ceramics and porcelains. He had a lot of consultation, and he was an easy case for us. Why? Because we have a general diastema, we have a small and short teeth, so there is no need to prepare that much. So as you see, I didn't change the anatomy of the teeth. I did the shade selection, and you see how the preparation is minimum. So impression, sending to the lab, it's ready now, it's the delivery date. Etching, you see the chalky surface of the enamel, which it shows that we are completely in enamel part. And then, as always, we start to deliver from the central incisors and cementing one after each other. And this is the case that we are done and finished at the time. He was here. These are temporary restoration. This is the definitive restoration. This case was here just for 1 week, and he moved back to United States. That's why I couldn't take pictures after a couple of weeks. You see a yellow point here. When we grind the teeth, when we do drilling, we cord pack, we do cord packing. So all of them traumatize the gums. So that's why we have this yellow point here. If the patient brush his teeth well, it's gonna grow up, and this black triangle will fill up with the gum after a couple of weeks. I didn't have the chance to see this guy after cementation. So this is the way he presented to me, and this is the final restoration, which he was happy, and he got married just after veneer cementation. All right, at the time, the choice for cement was choice 2 from Bisco company. It's a very common cement, and it's perfect for veneer cementation. This is another case. You see how the teeth look like. She was actually a dental student at the time, and she came to me for veneer consultation. You see how the teeth are short and small, and there's a generalized diastema between the front teeth. So she had a ortho consultation at the same time. So she was willing to do orthodontics treatment. And I told her, you know what, if you are going to treat your teeth, you should go for veneers. If you go for ortho treatment, the colic will close all the diastema, but the teeth should be veneered. Why? Because they are short, they are small, and we have to improve the anatomy of the teeth. So she was convinced, and I made the study cast, and I made the wax up for her, and I described the situation. We add wax on the medial surface of each tooth. By this way, we try to close the diastema. We had a very minor preparation. I just made the finishing lines, packing the cord. You see cord number 0 is packed here, impression with silicone materials, and you see on the labial surface of the central incisors, you don't see any light body there, which it shows that the prep is minimum here. We did the shade selection, and this is the definitive restoration. Okay, and you see how it looks natural. Nobody could differentiate, is it veneer or natural dentition? And she was so happy, and I believe it's a reasonable job. The cement that I chose at that time, it was Panavia V5 from Curare company. It's another choice. It's another aesthetic adhesive resin cements for this situation. Let's move on with this guy. He had worn dentition. This guy has an interesting story. He came to my office. He was asking to do my dental treatment in a week. I will pay you as much as you ask, and just finish it in a week. And I told him, you know what, your treatment procedure, it takes at least 5 to 6 months. So it's not doable. So what I did, I referred this guy to my neighborhood. I said, there are plenty of dentists that they can treat your teeth in a week. So he had consultation with my neighborhood dentist, and everybody claimed that we can prepare your teeth on Saturday and deliver all the restoration on Wednesday. The other one said from Saturday to Thursday. So he was a businessman going back and forth to different countries. He had consultation in Paris, and the dentist told him, you know what, you have to go to your local residency area. Why? Because the treatment is gonna take forever. I mean, take for a long time. So, and if any complication happens, it's better to treat your teeth over there. So he came back to my office and he said he's ready to go. You see the pictures in the beginning, how dentition is worn down. I believe in the beginning it was just attrition. Then we faced some abrasion in the area that we have a defective crowns, and also it ended up to erosion, because when we missed the enamel, the second stage would be erosion. So he was a case for reconstruction, and you see how deep bite he was. So as a prosthodontist, I made a bite guard for him. It's made by Impact. It's a wonderful acrylic material. It's easy to deliver, it's easy to adjust, and it's easy to make. So, and for the patient, it's really easy to wear. So he was happy with that. He had it for a couple of weeks, and then we moved on. I made a shell as a provisional restoration. I did a grinding preparation, delivered the temporary crowns. You see the lip line, you see how the edge of the central incisor follow the lower lips as what we got from the Dr. Atri, she presented yesterday, how to describe the smile for the patient. So we almost meet those requirements. And he was so happy, and he was telling me that the family member are saying he looks different. So he was happy at the point. You see the provisional restorations. From that point, since he was happy, the muscles were asymptomatic, so we moved on for the final impression. I made the impression. As you see, the height of the abutments are reasonable and above 4 millimeter, and I try to keep the convergency below 20 degrees. The final impression for the mandible, and you see the final restorations. This is the definitive restorations. I told him, you know what, I made you 28 perks and deliver it to you, and you have to keep them well and brush them well. So this is the way that he presented to me, and this is the maximum intercuspation position, and you see how different he looks. So for this type of restoration, which we met the requirement for a retentive preparation, the conventional cement, non-adhesive cement was fine. And I did use the Fujisem, is a resin modified glass ionomer from GC company. Okay. This is a case, actually I delivered it yesterday. She came to me like 10 days ago, and she was not happy with the appearance of the front teeth. So she told me, I want to do something. And I saw that the canines are intact. So grinding canines and make restoration, it's a risky part. So I prefer not to touch canines as much as it's possible. So I recommended her, just let's go for the 4 incisors. So I did a minor preparation. And then this is last Wednesday, I did some adjustment, and this is the final part since we are very short in time. So I try to be fast. And this is the final restoration. And this type of restoration was full zirconia. Actually, it's zirconia layered by feldspathic. We provided the aesthetic for the patient, and at the same time, whoever worked with feldspathic veneers, they know that we have problem. It's very thin, it's easy to fracture, and it's very difficult to train. But for the zirconia veneers, train it's easy, cementation is easy. There is just one point that we have to cover. The cementation, the bonding between zirconia and the tooth is a kind of tricky. So what I should do for this type of restoration, we know that we can't bond zirconia. So this is different. This is zirconia doesn't come with the glassy part. So I can't etch it. But what's the purpose of etching? When we do etching, we just make a micromechanical retention for the restoration. So for zirconia crown, we go with the sandblasting. So this type of restoration, we do sandblasting with the 15 micron aluminum oxide particles. And after sandblasting, we clean it up and we use the Z primers. And recently, Bisco company offered Z plus primer. So I use Z primer on the integral surface of the veneers, and then I do bonding on the tooth surface and applying the cement, like Calibra resin cements. That would be proper. It lasts forever, and I would say between like 100 veneers, zirconia veneers, just one fell off, and it wasn't due to the adhesive part. It was a cohesive failure. All right, we move on. The last case, she came to me like a year ago. She was a very young lady, and her dad brought her to my office. As you see, we have a diastema here, and we have a shortened teeth, which is very desirable for us. Why? Because there's no interference with the opposing dentition. So what I did, I just made the finishing line. I described that I'm gonna close up the anterior open bite, and I did the preparation, cord packing, cord number 1, Ultradent, which is my favorite, and impression. And this is the final restoration. As you see, how I did close the anterior open bite, and as far as shade, I go with the natural shade, and it's very natural, and the patient was happy. This is again layered zirconia veneers. Again, I did sandblasting on the veneers, Z plus primer, and Calibra cement for this purpose. Thank you, everybody. Thank you so much, Dr. Farid, for preparing this course. And if you guys have any question, please write it down in the chat box. Thank you so much.
Thank you. Thank you so much, Dr. Sadaku. Thank you so much. It was very interesting, very nice cases, and wonderful presentation.
Thank you, Sean. An hour.
Less than half an hour, in 20 minutes. So let's have break for 20 minutes. For 20 minutes.
الان من صحبت نمی‌کنم. چی بزنم؟ All right, colleagues, we're going to have a short break for almost 20 minutes, and we will be back for the next presentation, and hopefully see you soon.